Okay, let's get going with chapter 14, which is antimicrobial drugs. And just a quick cautionary note. This chapter can be quite technical. The goal here is not to memorize all of these drugs and what their actions are. It's more of just an introduction to general antimicrobial pharmacology. And the quiz is going to be a little bit different for this chapter. The quiz will actually kind of take you away from what we're going to talk about and show you how physicians actually choose the appropriate antibiotic for a specific bacterial infection. But it's a really good intro to basically drugs that you're going to come into contact with in your practice or possibly your personal life. I'm just going to caution you that the chapter is a bit dense, and my goal is not for you to memorize all this stuff. It really is to just kind of introduce you to this stuff. So first, I just kind of want to back into this term chemotherapy. I've used it before. It tends to evoke cancer treatment ideas for people, and that is true. I mean, treating cancer is a type of chemotherapy, but the word is actually much more general than people think. It's any chemical that is used to treat a disease or a disorder, or like any kind of medicine, basically. If you think about medicine in general, it's basically the science of knowing the appropriate chemotherapy or physical therapy or whatever kind of therapy. Just kind of expand your definition of that word. I will say that when penicillin was first discovered by Alexander Fleming, who just had really bad aseptic technique and grew mold and was like, whoa, this mold is like inhibiting the bacteria that I want to grow, everything has really changed since that moment in history. The US Army actually clinically purified and made commercially available penicillin in World War II. And that has really made medicine, I think, a golden age where we could treat all sorts of diseases. There were some other players historically that were, messing around and trying different chemical compounds and things for treating diseases, but it was really when penicillin was discovered that everything changed. And in fact, World War II is the first war where most people died of their injuries and not like a secondary infection as a result of those. I think we have just enjoyed such a great time for, controlling microbial growth with these types of drugs, that people have actually started to take them for granted. Some other things, I'm just going to give a shout out to Ehrlich. He is often looked at as the grandfather of chemotherapy. I don't know if that's entirely fair, but you know him from the acid fast stain. He was just kind of a tinkerer and liked to, test sulfur or different types of compounds on things. And he is certainly associated with the history of chemotherapeutics. Antimicrobial drugs are what we're going to focus on, and those could be for any type of microbe, a virus, a bacteria, a helminth, you name it. Antibiotics, a term that we are all familiar with. It's actually pretty rare for someone to have never had a prescription for antibiotics in their life these days. These are actually substances produced by a microbe, like it could be a fungus, it could be a bacteria, it could be all sorts of different types of microbes. They are produced by nature to give the producer some sort of a competitive advantage. Usually it's going to interfere with other types of microbes, or like it's a repellent or something. Who knows? But these are actually natural substances that we have basically just taken over, made better, made more pure, made more potent. Usually these are not discovered or created by humans. They're just kind of captured in nature and used for our purposes. The term broad spectrum is referring to the variety of bacteria that these drugs are going to work against. So a broad range is all gram positives and all gram negatives, and there really are some very broad spectrum antibiotics, like tetracycline, for example, is one that just kind of hits everything. Narrow spectrum antibiotics are going to have an effect on a very specific type of bacteria, possibly even a species level of bacteria. And I gotta tell you that this is where medicine is going. We need more identification of what is actually causing an infection, and then a very targeted approach so that we don't think about like the microbiome. We don't want to harm like your gut bacteria or your skin bacteria or the bacteria that you want to stay healthy. We have a much more sophisticated understanding of wanting those guys to be okay. Selective toxicity is also a concern here. I will tell you that there are some antimicrobial drugs that we will look at throughout the rest of this quarter, and they can be up to 10 or 12% fatal if you take them. That's very toxic. You kind of have to consider the advantages and disadvantages of every drug. Well, are you gonna die if you don't treat it? Well, maybe a 10% chance of death isn't so bad. That's actually something we need to consider. And of course, when you're using antimicrobial drugs, the closer that microbe is to you genetically or physiologically, like a worm infection, a helminth infection, for example, you're going to see more and more potential for selective toxicity to harm that host, which is us. If we compare different antibiotics, and this is kind of the class that we're going to focus on in terms of drugs here, things that are made in nature for bacteria, basically. They can be different by where we found them, their chemical structure, their chemotherapeutic index, like where does it actually go in the body, what is its action, bacteria static versus cidal, like remember that means does it just inhibit their replication or does it kill them? Their spectrum of activity, like I mentioned, is it just for a specific type of species or is it for all bacteria? Their pharmacokinetics, that's kind of like how it is moving in the body, at what dose does it need to be concentrated, how fast are your kidneys or your GI tract going to get rid of it? All of those things need to be taken into consideration. The site of its action, like is it going to be peptidoglycan, the plasma membrane, DNA, all sorts of different options. It's not always like penicillin, the classic peptidoglycan inhibitor. Interaction with other agents, I think, is really interesting, especially with non-Western medicine. If you think about it, grapefruit juice can actually make like blood pressure medication toxic, and I would not even consider grapefruit juice a medicine. I would consider it a food. Like if you just look at the array of different chemicals in the world, we need to consider that there can be chemicals that intensify drugs or that can even neutralize them or make them completely toxic. I think the most important thing from this chapter is going to be to evaluate this phenomenon of drug resistance and what we need to do about it as a society. I mentioned toxicity is always a concern, and more I am seeing a conversation about how much these drugs cost. There is a real disincentive, as you will learn in this chapter, for drug companies to actually manufacture antibiotics because you only take antibiotics until you're cured and then you don't want to like take those drugs anymore and nobody wants to pay a lot of money for them. So it's not a very profitable enterprise for our pharmaceutical industries, and that is a real concern. Also, we just need new drugs, I guess. Someone's going to have to do that research. Let's take a look at the action. This is like a typical bacteria here. Remember, it's pretty structurally similar. And while we're not going to like memorize all these drugs for sure, it's good to know that they can act on different structures. Cell wall is a great one. Peptidoglycan, a completely unique bacterial structure. That is one where there should be no host side effects, right? Except maybe if it's a broad spectrum and it kills, your good guys. That's a really powerful action that definitely is what penicillin does and a few others. The plasma membrane is another really good area of attack for drugs. Polymyxins, I'll just mention that. That is one of the three antibiotics in a triple antibiotic ointment, such as Neosporin. So you should totally check out the labels for all of your stuff in your like first aid kit. Polymyxins is great because everything has a plasma membrane, and gram negatives actually have an outer membrane, so it's kind of get double hit with those. Ribosomes are another area that all microbes have, all bacteria have. This can be a fairly broad spectrum type of action that way. So tetracycline is in that category. Tetracycline is often prescribed for acne. If that sounds familiar to you, it can be really common for lots of people to control their acne during their teens. Metabolic pathways are kind of interesting. I think this kind of starts to narrow the field a little bit when it's a specific metabolic pathway, and there's lots of drugs that are going to do that. Also, genetic material synthesis, DNA synthesis, RNA synthesis. Those are some really powerful drugs. I'll mention Cipro. I'm going to call that one out specifically. Cipro is a very powerful antibiotic. We use it for UTIs. Treating a UTI can be incredibly tricky because you have to get that drug into the urinary system, and usually that urinary system breaks down the drugs as it enters, which makes this have to be really potent. We think that Cipro, by the way, may be responsible for some of the symptoms of Gulf War syndrome, which is something that a lot of our veterans have experienced from the first Iraq War, and it's kind of one that's on my radar as being a concern. But here's the deal. We can target bacterial structures with a bunch of different ways. A bunch of different drugs are going to have a completely unique way of harming or putting that microbe into stasis. Please do not think that all antibiotics just attack the cell wall. It is, though, a good place to start. And I would say some of these drugs might actually look a little familiar. Penicillin, cephalosporins, which are kind of newer drugs, they're kind of much better because there tends to be an enzyme that bacteria have developed that will actually reject penicillin. Like they kind of get this penicillin penetration, and then this enzyme that they may or may not have will either chop it in half or just spit it right back out. So cephalosporins can work a little bit better than penicillin, just because I think penicillin's been around for so long they're just over it. One of the things we can do with these cell wall inhibitors is kind of not look for new ones, but to look for tweaks in the molecular structure. So this is not a chemistry class, just relax your eyes. Do you see how these molecules have some similar cores? Like there's a little square nitrogen component, there's usually like a ring off to one side. The way pharmacology works now is we're not reinventing the wheel. It takes too long, it costs too much money. What we're gonna see more and more are these little tweaks to a end of a molecule, or hey, let's glue this one little piece on there and see if that gives it some extra like abilities. All of these drugs have something in common. They have this common structural core. I will also say if you see any suffix like ampicillin, methicillin, amoxicillin, penicillin, it's probably just a derivative of that original penicillin that Fleming was playing around with. Those have really developed into a whole array of related but somewhat distinctive drugs that might have its own little action, or maybe it can be taken orally, or maybe it has to be through the IV. Just sort of depends. This might be a good time to revisit MRSA. We haven't really seen it since we talked about spider bites, but MRSA used to be the big, scary nosocomial infection. It's not anymore. I gotta tell you, we've got some new horrible things happening in terms of hospital-acquired bacterial infections, but MRSA stands for methicillin-resistant Staph aureus. This is an aggressive bacteria when it gets past your skin barrier. So if this is on your skin, I wouldn't worry too much about it, but if you get a scratch or a pimple or some sort of entryway into your inner delicate tissues that don't have the same defenses as your skin surface, this can be quite aggressive. aggressive. Because it's resistant to a whole bunch of antibiotics, we are very careful with MRSA. There is IV vancomycin that is kind of the drug of last resort. This is much more potent than it would be taken orally, but it is scary to me how much I see vancomycin prescribed in the real world, because like the ability for this to get resistant has already been documented. The topical treatment that you would do if you didn't have like MRSA like inside your, muscles and things would be bacitracin. Bacitracin, by the way, is another one of your neosporin antibiotics, which is great because your skin is covered with staph. It is supposed to be covered with staph. It gets into the wrong place at the wrong time and it can go crazy. The other option, if we can't get this with IV Vanco treatment, is a surgical removal of all the involved tissue, which is pretty catastrophically horrible. Okay, back to the boring stuff. Our next big action is going to be protein synthesis inhibitors. And these are some big drugs. Protein synthesis is a really complicated pathway. Here's what you need to know. There are drugs that can interfere with pretty much every step of that process. The ribosome, the transfer RNA, the mRNA, you name it. This is a really sophisticated biological path. We're going to have some really cool drugs that are getting in there somewhere. And tetracycline, I guess I mentioned that one. This is one that can kind of like jimmy up that ribosomal attachment, and then you can't make proteins, which means they're unable to do any chemical reactions. Other metabolic pathway inhibitors, kind of outside of protein synthesis, basically, which is definitely a metabolic pathway, they're just going to screw up different enzymes. Just some kind of specific thing that bacteria has, the biosynthesis of it is now inhibited. They're cool. Antifungal drugs, these are really interesting to me. I will be really honest with you. We don't always know how these drugs work. We know that they work. We assume that it's some kind of anatomical target, like maybe chitin in the cell wall. That would make sense to me because it's kind of specific to fungal like organisms. But honestly, there is a little bit of a question mark in terms of the biochemistry in my mind. So just know these are really cool drugs. Treating a fungus is really difficult because, of course, a fungus is a eukaryote, and that means the host has more similarity, which is going to invite more side effects and potentially require a longer and higher dose of that medication. So I'll give you the example of treating something like athlete's foot. Athlete's foot is usually very unsuccessfully treated. In fact, I don't even know if it ever works. It's really easy to pick up, and if you don't do it exactly right for 30 days, it's all messed up. And there's actually some guidelines that are coming out of health authorities that are like, maybe we just shouldn't care about athlete's foot. It's just not worth it, especially when you look at the cost. And I mean, it just comes back anyway we're not going anywhere anytime soon, but like when we go back into the real world and go to the swimming pool or whatever, boom, it's back. Antiprotozoan drugs, and this is a cute little giardia. It's got two little eye spots. They're not eyes, but they're kind of like little dark occlusions, but I always see eyes when I see it. It looks kind of like a little fish. Chloroquine is actually the drug that treats malaria. You've probably been hearing about chloroquine or hydroxychloroquine. There's all sorts of interest in these drugs, but it is a drug that inhibits the DNA synthesis of protozoa. Questionable how that would transfer into a virus, but I'm gonna throw it out there that this is still a drug that has a lot of usefulness, particularly in malaria zones of Africa and South America. The theme about how do these work, we don't really know, but they seem to work, is actually really true. And I'll kind of use chloroquine as an example again. Back in the day, before we had a lot of chemotherapies for things like malaria, African safaris used to serve a gin and tonic at the end of the day, and it's actually really interesting that they did that because tonic water actually naturally has some chloroquine in it. Like if you taste tonic water, to me, it has like a metallic taste. I don't know how to describe it. It doesn't taste like water. But they kind of anecdotally knew that that created a little bit of disease resistance in their safari patrons or whatever. And so, like, just that story about, oh, well, just have a gin and tonic, you'll be fine, actually sort of developed this drug pathway, which I think is just like so cool. Okay, in terms of worms, I did mention that, in the United States, we don't have a lot of worm infections. There are some, but this is really a much bigger problem in the tropics. So, of course, people are going to travel and all this kind of stuff. There's people who need medicine from other parts of the world. We do have some classes of drugs that work on worm infections. But if you just kind of look at this list, none of them kill that stupid worm. So if you've got tapeworms or flatworms or flukes or whatever you've got from probably dirty, poopy water, this is tough therapy. This is actually an animal. This is going to need the highest dose. Some of these actually get really large too. So not just a high dose, but a lot of it over a long period of time. What frustrates me is that these don't kill and remove the worm. That just sucks to get worms. Antiviral drugs. We do have some antiviral chemotherapies, and it kind of just depends on what the virus is. One that we're going to see quite a bit is a drug called acyclovir. Acyclovir basically gets into the DNA replication cycle of a virus, and this works really well, particularly for lysogenic viruses that are DNA viruses that can basically go into a latent phase and then reawaken. So that's herpes. Herpes would include oral herpes or cold sores, genital herpes, chicken pox, shingles, anything in that herpes class, and there are multiple, would very likely be treated with some kind of acyclovir. This is the big question that I want you to ponder about this chapter. It's so important. Your reflection paper for this unit will be on this issue, and I think it will be a little bit more impactful than just my disembodied voice. But I will say that we are living in an unprecedented time in medicine where we are losing the battle with drug resistance. We have used so much chemotherapy in the last 75 years or so that these microbes have had no choice except to evolve resistance. I mean, these are natural chemicals, and we already know that they have mechanisms to change themselves. But one of the really interesting things we've documented about bacteria in antibiotic therapy sessions is that they relax their DNA proofreading, which means they accelerate their rate of mutation. It's not even steady. They're just like, what the heck? I'm going to just mutate all over the place to see if I can get some sort of advantage. That is where resistance starts. They naturally have this ability. And then we'll kind of see some other perhaps negotiable issues, like the fact that we misuse antibiotics. We hoard old antibiotics and use them because we don't want to go to the doctor. We have misdiagnosis of a viral disease that should never be treated with antibiotics. If I haven't said this already, allow me to repeat myself. Antibiotics are appropriate chemotherapy for bacterial disease only. If you don't know what's wrong with you and you go to the doctor for a cold or flu and you get antibiotic as a prescription, you should get your money back, because that's part of the problem. You're just saturating antibiotics in your body and allowing the bacteria to kind of experience that and potentially mutate some sort of advantage over it. I will also say that we use the majority of our antibiotics in the United States in animal food. We give them to chickens, cows, sheep, pigs. 80% of our consumption of antibiotics actually goes into our food supply, and we eat that food. We're kind of getting low-level exposure. The animals are getting this constant antibiotic therapy their whole lives. So of course they're going to have resistant bacteria. It's just a nightmare. Sometimes people don't take the full dose, and I'm just going to put out a cautionary thing there. We're looking at that. We're actually revisiting the course of therapy, and I have some questions about how those days, oh, this is a 3 day pill, this is a 5 day pill, this is a 10-day pill, that's kind of being evaluated again. And we might have more constructive guidelines about actually how to take a course of therapy that is the most appropriate rather than a standard approach for everybody, even though they have different bodies and different levels of infections. A couple questions just to kind of have deep thoughts about. Do we need to make antibiotics more expensive so that people don't have easy access to them? It's a question that we're wrestling with. And also, patients want a prescription when they leave the doctor. It makes them feel like they got something for their money and their time, maybe. We got to stop that. We got to have more laboratory diagnosis of what's actually wrong with people rapidly. And then we need to educate ourselves about what's the appropriate reason to have antibiotics. Couple things that also I will use in terms of words. Synergism and antagonism. Remember, there can be interference with other chemicals. This could be an advantage or a disadvantage. If it's like we can combine two drugs and get like a super drug, that is synergism. Antagonism, though, is a cancellation, and that antagonism is definitely a concern. So weakened microbes in some cases can cause those mild symptoms, and that's good because that means you're going to get really good immunity to that. You are going to probably have memory to fight that stuff up for a while. I prefer dead, but I will say the dead probably is not as strong as the weakened. So the other kind of criticism I have about a lot of these weakened and dead vaccination methods is that in the United States we tend to prefer our virus grown in eggs, which is, honestly, it's a disaster. Like, they're not human cells. Of course, growing the virus is potentially going to cause changes in the DNA of that virus. And, if you're allergic to eggs, you can't get these vaccines. You have to have a different variety. So, boo. The other kind of thing that is sort of old school is a vaccination for your immune system to recognize toxins. And this is pretty standard stuff. Tetanus, diphtheria, those basically produce toxins. We definitely have microbes that produce toxins, and we want to be protected from those chemicals as well. Newer vaccines that are a little bit more interesting to me are adjuvant or conjugate vaccines. These are highly sophisticated pieces of a microbe. If you've had anatomy and physiology, you might recognize the term epitope. It is the very tip of a surface molecule or antigen that will train your immune system and should be actually a little bit more universal or broad spectrum, I guess, than just your typical attenuated or dead vaccines. DNA vaccines are also kind of interesting to me. I'm hearing more and more that these are ready to be deployed. Basically, we can inject genes into you, and these can come from basically a virus that we have taken over and cleaned out and put these cool like vaccine genes in there and allow your body to incorporate that DNA so that it builds antibodies or different immune reactions to things. This could basically cure cancer before it starts. I don't know. There's all sorts of ways that this could be cool. But I will say it's a little bit of tomorrow medicine, but I'm excited about it. You should know that we do have some drugs coming. It was a big mandate a few years ago, and I'm excited about that. Like, I think we still need more, but we do have some. So don't freak out too much after the video and your reflection paper. We are working on it. We're looking to nature, plants and animals for different inspirations. Antisense agents, if you've ever heard of a drug cocktail for HIV, like that is AZT, that is... it's a drug that basically interferes with how your nucleotides are laid down in mRNA or DNA, which is really cool. I also am super excited about bacteriophages. Remember, these are viruses that attack bacteria. And before we had antibiotics, You should know that there was two big superpowers for medicine. There was the United States, and then there was the Soviet Union. Soviet Union was really into bacteriophages. All of their medical diagnostic and treatment facilities were geared towards finding viruses for different type of illnesses. And oh my god, you guys, they had cures for cholera and just about every type of diarrhea caused by a bacteria. But once we discovered penicillin, people were like, yeah, I want to take a pill, I don't want to take a virus, sounds too weird. But we're revisiting that now, and I wish we got along better with Russia, because they have all of this wealth of historical knowledge. I just think this could be the answer to some of these resistant microbes. Also, I'm just going to put this out here, some other exciting possibilities that are not yet in your book. Draco basically is a drug that tells virus infected cells to kill themselves. I just think this is cool. Your cells all have a suicide program, and sometimes, when things get bad, they trip this suicide and then they're done. They don't have any more virus being replicated inside of them. Draco basically recognizes this sequence of events that viruses all do, and I mean, this is universal. Draco could actually be like, okay, now we have a medication that can tell any cell infected by any virus to just die. And I don't know, this is still definitely in vitro, but I'm excited. Other things, I think looking at animals is the way to go. There's definitely behavioral, dietary changes that animals make when they're sick. And what we really need are some microbiologists to just follow sick animals around and see what they're eating or, what they're doing to themselves. And then see if there's any kind of drug possibility there, which I think is really cool. It's a new area of pharmacology called pharmacognosy. And it's basically a field of looking at native people medicine, animal behaviors, and then harvesting whatever that is, taking it to the lab and doing the actual hard science to see if it works or not. But I think that this is a really interesting possibility. Some non-chemical things that might actually be interesting to you. Shark skin tends to repel microbes. It's really cool. It kind of feels like sandpaper. This is a scanning electron micrograph. It's shark skin on the bottom. It kind of looks like really, really sharp, sort of little daggers tiled together. That's actual shark skin. What's on top of it is actually nanotechnology that we have produced to mimic the effect of shark skin. Is it shark skin? No. But we could build our boat hulls out of it. We could build our prosthetic metals out of it. Imagine if just bacteria couldn't land on it. That could actually be a really awesome option. I did ask for shark skin lab tables. They said no, but I can still dream, right? I also read an article about these gecko skins and cicada wings. Gecko skin is weird. It allows them to stick to glass, basically, which is kind of amazing. And cicadas are these horrible bugs that crawl out of this, I don't know, dirt every 7 years, and they make this horrible sound. We don't have a lot of that stuff here, but it's cool. So gecko and cicada wings, and these are SEMs of that, basically are lethally sharp to microbes. So I don't know what the application of that would be, if we could get cicada wing band-aids or something, or at least artificial cicada wing band-aids, but I'm very interested in using physical ways of repelling microbial growth, and not chemicals, because there's no way that bacteria can get resistance to a dagger, right? Other interesting options, I'm all interested in the topical or skin application of essential oils. We use tea tree oil, all sorts of oils for all sorts of reasons. I do not endorse ingestion of oils. I'm sorry. It thins mucous membranes and it can actually cause poisoning. It's especially really bad for animals. If you're aerosolizing or diffusing different types of oils into the air, it can make animals really sick. So, skin only is my endorsement. Quorum sensing is interesting. Quorum sensing involves that nanowire. Remember that they have an electrical connector and they all communicate. Quorum sensing is basically where we send an interference signal to block them. And quorum sensing is important because what they're coordinating together and communicating about is when to release a tidal wave of toxin. They don't all just release a little toxin at a time. They all wait until they're huge population, and then it just releases all the toxin all at once, which is just completely overwhelming and causes sepsis and organ failure. We have some other kind of cool things. I think I mentioned the silver. I just think it's really funny that it's a silver bullet. I was like, what? I don't know. That's cool. And then we are starting to penetrate the biofilms. I don't know. We're working on it. Snaps is one more thing that I just think is really cool. These are like little ninja throwing stars that are super sharp. And in vitro, this has not been tested outside of the lab yet. I would actually say this is still in the academic portion of the world. Snaps are completely effective against all of our terrible big bad resistant bacteria. So here's kind of where we are. I'm not even going to say that drugs are losing their efficacy. We're already at that point. We are in a post-antibiotic era. It is going to be harder and harder to treat these resistant infections, and hundreds of thousands of people will probably die before we have a solution to this problem. So there's all sorts of, things that we might try, but I want you to ponder this question. What are the reasons microbes are becoming resistant, and what do you think we should do? And I'm just going to be really honest. Throwing money at this has not actually mattered. We kind of want some outside of the box thinking here, because asking pharmaceutical companies to do research pro bono is just not gonna happen in our society. So think outside the box. I think that this is a really super important issue.